So let me start the meeting now. So good afternoon, one and all present here. So I'm Charu here on behalf of IPCF Group. We are very happy to have this session on the World Health Day, which is today, 7/4/2022. Now we will have a small clipping about the journey of our IPCF till date. I'll give you a summary of the agenda. So we'll have Master Abhishek Kumar Jayswal, who will be teaching us few effective mudras. And next will be Dr. Manoj, who will be talking on the side effects of androgen deprivation therapy, followed by the question answer or the doubt session. Before we start with the yoga, the mudra session, so I will just give a small introduction about our yoga master. So I welcome Master Abhishek Kumar Jayswal, who has an MA degree on applied yoga and human excellence from Dev Sanskriti Vishwavidyalaya, Haridwar, to teach us few effective mudras and how it improves with the various functions of our body. So on to you, sir.
Namaste everyone. My name is Abhishek. So today I'm going to. Today we are going for teaching. I will explain. I will explain about the mudras, how to work in our problems, and how to maintain that with the some mudras and some breathing practice. And also, you can ask me after that if you have any doubts. You can let me know. So first, I want to know about any recently surgery and all that. Any, sir? All right. So now I will explain what we have to do. I will explain also who have recently surgery they should avoid. Who's no happened since 1 year or 6 months or 9 months. They can do accordingly what we will go with that, right? So basically in a prostate we have two mudras for that especially. One is called Aswani Mudra. Aswani Mudra, I am explaining about Aswani Mudra is the technique. What is the technique? I will come after that the benefit, and then after I will show you how to do that. All right. So it's a two mudras there. One is called Aswani Mudra. The technique I will explain first how to do that. The technique is for Aswani Mudra. You have to contract your pelvic region with exhale and squeeze there and hold for 5 to 10 seconds. 5 to 10 second hold and then release. Again, you have to contract your navel part and your anal part and your pelvic region with exhale. You have to contract inside and release. You have to contract with exhale. Remember, with exhale you have to contract for 5 seconds to 10 seconds if you can, and then after release. That's the practice you have to do when your stomach is empty. That means you can go with the morning after your fresh, after all this stuff happens. After also you can practice at evening before the dinner. Before the dinner you can go with that. The Aswani Mudra. Basically, the advantage of Aswani Mudra, it's a make your prostate size healthier. Secondary, removing all the bacteria surround there who protect your organs properly. Third is benefit to work your organ properly. That is the main major benefit of the Aswani Mudra. Most important part in this case, it's a detoxify your body. Simple. So for that you have to take right amount of water to passing all these toxins. Secondary, you have to go accordingly your food to not accumulate fat into your body. Toxins. If you eat something, it's not digestible, it's something there, so that will be accumulate in the fat, who is not good for the prostate, especially in prostate cancer, in prostate problems. So make it clean your body. For that you have to do some physical activity. All right, this is for the Aswani Mudra. Next, you have to Vajroli Mudra. Vajroli Mudra, that's what we have to do. That is also the contraction. With exhale, you have to contract your abdomen, contract your pelvic. I will show you. Yeah, you have to contract this part, and sit with chin up and hold as much as you can. This is called Vajroli Mudra. So overall, that all the mudras to improve their functions and remove all the toxins from your prostate area and this part. All right. So this is the basic mudras for the prostate. All right. Secondary, you have to go. You can add some more work exercise in this problem. It's one is Kapalabhati. Also, you can do that. Kapalabhati also work in your prostate. Whatever urinary problem, you have to get cure with these practice. Kapalabhati, you know very if you know about yoga, you know very well about the Kapalabhati, which is the exhale and contraction in one thought. Contraction from this part, we have to very careful our pelvic region. We have to focus our pelvic region while exhaling front, exhaling contracting. This is we have to go with that. So three you can it's more enough if you are practicing regularly every single day. But I request you in your problem, in your this thing, we have to make sure our food habit, our lifestyle. That is the matter more than the any workout. To be honest, so you can go with all with this. If you have any doubt, if you have any confusion, you can ask me. All right. Any confusion, sir? Any confusion? So, ma'am,
Yes,
Charu,
sir.
ma'am.
Yes, sir.
So yeah, that's my this thing done.
Okay. So anybody has got any doubts, like you want to perform that and see when master is there?
Yeah, if you want, I can show you. Aswani Mudra, again I'm going to repeat. Aswani Mudra, you have to contract your anal part, contract your pelvic with exhale, hold 3 seconds or 5 seconds, again release, again contract. You can practice first 5 to 10 times, then after slowly you can increase. Morning after and after you have to perform, and evening before the dinner. This is Aswani Mudra. Vajroli Mudra also you can do that same time, morning, evening, and that way exhale, contract, and stay there and release after that. This is also you can Vajroli Mudra. Kapalabhati, it's a beneficial 90% benefit of this problem is Kapalabhati. To be honest, Kapalabhati you can go first 20 counts, 30 counts. Accordingly, you can increase. Kapalabhati is while exhale, contracting pelvic, contracting your diaphragm. So more you have to keep in your mind, focus on this part. All right. So this is the practice. You can go with that.
Yes, sir. Yes. Thank you so much, sir. I believe you all would have really benefited from this. And now I would welcome Dr. Manoj Tummala, consultant urologist at Urology and Robotics Institute, Private Limited, Chennai. He has done his fellowship in uro-oncology from the prestigious Tata Memorial Cancer Center, Mumbai. He's here to take a talk on the side effects of androgen deprivation therapy, ADT. So let's welcome.
We are thinking of doing an interactive session now. So I think many of you have undergone surgery and few people have undergone androgen deprivation therapy also as a part of your multimodal treatment. So I'll be discussing about the side effects of the ADT, which is very underrated and very few thought out. So we'll discuss about the ADT side effects and we will know what to do for these side effects to come down as little as possible. So let's start the thing now. So the androgen deprivation therapy is one of the most important thing developments which happened in the prostate cancer management. So the foundation of androgen deprivation therapy was started way back in 1940s. So there is this gentleman called Charles Huggins. He was credited to discovery of usage of androgen deprivation therapy for prostate cancer. He only discovered that prostate cancer cells respond with low testosterone levels so that the disease can be controlled. So the initial thing was started in 1941. So when the patients who are discovered with prostate cancer who are metastatic, so when they undergone orchidectomy, that time there is only orchidectomy. So when they did a orchidectomy, that is removal of the testis, then the testosterone level in the body falls down to the suppression levels. In those levels, the cancer cells, the prostate cancer cells, we are able to control the disease. Even the patients who are having bone pain, bone discomfort because of the metastasis to the bone, when they undergone the orchidectomy, when the testosterone levels are suppressed, there is symptomatic relief for these patients. So this is how it started that this testosterone level suppression can cause cancer control in prostate cancer, and subsequently he was awarded the Nobel Prize also for his discovery in 1960. Okay. So what are the androgen deprivation therapy we are using now is all credit to this person called Charles Darwin. So how this androgen suppression acts is the testosterone secretes either from the testis or from the adrenal glands, which are above the kidney. It's a small adrenal gland which are 1 centimeter or 1 to 1.5 centimeters above the kidney and the testis. So these both organs in our body will secrete the testosterone. The testosterone level is maintained by the higher center, that is the brain. Inside the brain, there is one hormone called GnRH. This hormone stimulates the testis or adrenal glands to secrete the testosterone. So what are the medications we give? We give you leuprolide, you should have given bicarotenide, you should have given the other androgen suppression therapies, mainly act on the pituitary area, this is the hypothalamus area in the brain to suppress the testosterone level. We'll show you how it does. Then we'll discuss about the side effects. So we would have given androgen deprivation therapy, that is starting off with injection, hormone injection. Either if the patient is having in a metastatic state that the disease is spread to other organs. So to control the disease, we'll be giving androgen deprivation therapy. Or the patient who are having intermediate and high risk prostate. So me or Anand sir would have explained you whenever you are having the disease, after getting the biopsy, after getting the Gleason score, after getting the PSA, we'll be discussing with you whether you are having a high risk disease or intermediate risk disease. So either patients who are having metastatic disease or patients who are having a high risk or intermediate risk patients who are going for radiation, not for surgery, who are going for radiation will definitely get hormone therapy. Patients who have undergone surgery, then the main specimen, the main prostate specimen will be analyzed, and if there is any risk factor, then only we will start this hormone therapy. Okay. So intermediate risk patients, only in the intermediate and high risk patients, no role of starting ADT after undergoing surgery. I think most of your patients, most of you are undergone surgery, so you would have not started any androgen deprivation therapy immediately. Only after seeing the biopsy, if there is any margin positivity, or if there is any nodal positivity, or if the disease is spread little aggressively to outside of the capsule of the prostate, we would have drawn your diagram and showed you. If thing is there, then only we'll start the androgen deprivation therapy, this hormone injection. Otherwise, we would have not started. But it will be started when you opted for radiation. If you opted for curative radiation, definitely we would have started androgen deprivation therapy along with the radiation. Surgery, it will be plus or minus depending upon the main biopsy. So what all the therapies we have here? The orchidectomy is considered as the old. I told you 1940s it was started. That it is the cheapest way. It is the most significant way where we can suppress the testosterone. It's a one-time procedure. We will do the procedure under local anesthesia, not giving any final anesthesia also. Under local anesthesia, we'll be removing both the testes so that the testosterone suppression can happen. This is the most, it started in 1940s. Now also we'll do for some patients who are not affordable for hormone therapy. The other drugs which we give as injections are, we are called as GnRH antagonists or agonists. Don't get into these things, agonists or antagonists. Agonists are which stimulate the testosterone production, and as a negative feedback, if the testosterone production is increased, as a negative feedback, the pituitary will stop the testosterone suppression. This is called as agonist. Whereas the antagonist, it will straight away stop the testosterone suppression. I'll show you the diagram so it will be easy for you to understand. So as I told you, architectomy, removing of both the testes is a primitive thing which is done from 1940s to till now. So the advantages are, it is very economical. So it is one time if you don't know, the patient need not pay for the hormone therapy each and every time if you undergo. But what is the disadvantage is the permanent procedure. If you remove the testes, there is no way we can get back the testosterone production again. So it is a one-time procedure. It is a permanent castration. If we want to stop the androgen deprivation therapy, we cannot stop. Hormone injections, if we give it, we can take it for 3 years, then we can stop it. So the testosterone production will improve. And again, you will have the side effects of the testosterone suppression can be reduced. But in orchidectomy, it is a permanent procedure. It cannot get back the suppression effect. Coming to the GnRH agonist, it is nothing but it's a hormonal injection which you would have taken. It is the most common injection which we give, leuprolide. Leuprolide injection you would have given. No, this is GnRH agonist. So it helps in initial increase. It releases it stimulates the brain to increase the production of luteinizing or LH hormone, which increases the production of testosterone. So initially there will be a flare up. Initially there is a surge. Initially there will be increase in testosterone production. Then it becomes a negative feedback mechanism. It negatively suppresses the production again. Back to after 1 week, the testosterone production will come down. So it is called as GnRH agonist, leuprolide, which we commonly give. So there are various formulations, leuprolide, triptorelin, or camerolin, or it's goserelin. So these are the available trade names. What we commonly give in CURI is leuprolide. Most commonly given dosage is 22.5 milligrams. We give for 3 monthly dose. 3 monthly patients usually come. They'll do a PSA test, and after doing a PSA test, we'll give the hormone injection again. So usually in high-risk prostate cancer, we'll give this therapy for at least for 3 years. For intermediate risk, we'll give for 1 year. This is what dictum in the guidelines. Both European Association guidelines and American Association guidelines suggest for high-risk patient, you need to give leuprolide injection for 3 months. 3 monthly injection for at least for 3 years. For intermediate risk, we need to give for 1 year. So no drug has any proven superiority over the others. As of now, in all the trials and studies which have done, all the drugs are equally suppresses the testosterone levels. The annual cost will be somewhere around 60,000. So coming to the antagonist. So the advantage of antagonist is whenever you give an injection, it won't take suppression for 1 week to happen. It will suppress the testosterone immediately within 24 hours. And there is no flare up, there is no initial surge of testosterone. So this is, but the problem with the antagonist is it is expensive. It costs you around the initial dose itself it costs you around 35,000, and it is a monthly injection we need to give. Leuprolide will give 3 monthly, but this antagonist we have to give monthly 1 injection. So it is little expensive when compared to antagonist. So it will straight away block the testosterone suppression. It won't increase the testosterone production initially. It will straight away block the testosterone production whenever you give injection. So within 24 hours, you will have suppression of testosterone. That is the advantage here. So the loading dose is 240, and we have to give monthly dose of 80 milligrams. The annual cost of this is somewhere around 1.5 lakhs. So 1.5 lakhs, that is compared to 60,000, and there is no added advantage. So that's why we prefer giving you leuprolide than giving this antagonist. So recently there is a trial going on. It is called as the HERO trial, HERO trial. So we are also waiting for this trial. In India, the drug name is called as Relugolix. So this is not an injectable form. It is an oral form. You can take it as a tablet. It has the same effect of taking leuprolide or injection or anything, but this is a tablet form. It is a little expensive when compared to leuprolide or any other drug, but it is still not available in India. There is a recent trial called HERO trial, which has an added advantage of 54% of decreased side effects when compared to any other drug available in the market as of now. So the drug is expensive. We need to see the more pharmaceutical companies take over this formulation and come with a competitive price. So in coming years, the price will come down. So coming to the side effects of ADT. So this ADT, this androgen deprivation, this testosterone suppression, we cannot avoid. We need to give. So we cannot avoid the side effects of the drug, but we can bring the side effects to a reasonable limit where we can control it to some extent and give a proper treatment so that it won't bother you in this coming years of 3 years or 1 year when you're taking ADT. So the most common side effect of androgen deprivation therapy, that is low testosterone level, is osteoporosis, that is decrease in bone mineral density. So already most of the patients who are having cancer prostate will be about 60 years, and most of the patients will have little decreased bone density because of the age factor. And taking this androgen deprivation therapy, low testosterone will cause more loss of bone mineral density, and most of these patients will have risk of fracture. So these patients should be treated. All of these guys who are taking ADT should be given calcium supplementation. That's why any patients who are on Leuprolide, we advise them Shelcal. Shelcal is nothing but calcium supplementation. We ask them to take Shelcal XP. I'm trying to tell the product name because you'll get to know that you're taking it. Shelcal XP, which contains both calcium and vitamin D supplementation. So both of them are necessary to increase the bone mineral density so that the calcium which is you are taken by tablet form will get absorbed and taken into the body, and this absorbed calcium will again deposit in the bone so that the bone mineral density won't come down. So patients who are symptomatic, who are having back pain, who are having thigh pain and hip pain, some patients may require this bisphosphonate therapy, particularly in metastatic patients who has bone metastasis. They have more osteopenia or osteoporosis when compared to normal patients. So those patients require this palmodronate or zoledronic acid. So these are nothing but drugs which help in bone resorption. That means absorption of calcium from the bowel. When you eat food or when you take the supplement, it absorbs the calcium more and it deposits the calcium more into the bone. Okay, so that is the advantage of zoledronic acid or palmodronate. But usually we give in symptomatic patients, not in every patient who are on ADT. Some patients may acquire, will have hot flashes. That means subject to feeling of warmth on the chest, on the shoulder region, on the head and the neck region. So this is a subject to feeling of warmth of upper torso and followed by objective perspiration. Sometimes some people will have sweating also, particularly in the neck and the chest region. So this is common because of the increased estrogen levels. This warmth and the perspiration can happen in the patients who are having low testosterone levels and high estrogen levels. Sexual dysfunction. This is the most common thing. Because of the low testosterone levels, the erection won't happen. So even we do a nerve sparing surgery, particularly we try to preserve the nerves to help the patient to have a normal erection. If the patient is taking this suppression therapy, most of the patients will have erectile dysfunction and it have loss of libido also. The interest to participate in sex will come down due to this suppression therapy, and it is inversely related. So when you take the suppression therapy for a long time, the sexual desire and the erection also will come down drastically. So it will improve once you stop the suppression therapy. But if you do an orchidectomy, which is a permanent procedure, this can't happen. The sexual desire loss will be permanent. So that's why we advise patients who are economically able to get the medication of 60,000 per year. This intermittent androgen deprivation therapy, that is the hormone giving injection 3 monthly, you can stop it for some time. That is the advantage. We can stop it and patients will regain their sexual function again. And whenever we start the hormone therapy, they will come down. So in between, we can do it, intermittent therapy. Coming to cognitive function, low testosterone will decline the cognitive function also. And people who are having decline in cognitive function can have the depression and anxiety disorders also, which is seen in around 12% to 15% of the patients. So this is commonly seen in patients who are having low testosterone levels in elderly people, and suppression therapy also will aggravate this. And it can also cause decrease in muscle mass. So usually patients who are having this androgen deprivation therapy, we advise these patients to take a 1 kg dumbbell and do a regular exercise so that they won't lose this muscle mass. Muscle mass is most important. Patients who are having low testosterone will lose their muscle mass and increase their fat deposition because of the high estrogen levels. So whenever the testosterone is suppressed, estrogen, which is a female hormone, will be elevated. Whenever the estrogen is elevated, the patients will have hot flashes, gynecomastia, that is enlargement of the breast, and patients will have high fat content, low. So all these are female hormone estrogen related issues. So after 1 year of ADT, there will be a decrease in body weight, particularly seen in all the patients. There will be 2 to 3%, 4% of patients will have this muscle mass, decrease in muscle mass, increase in fat content. And testosterone is particularly helpful to maintain a series of functions in the body. This is called as metabolic syndrome. That means it has the cardiovascular effects and it has diabetes also. There is an increase in insulin resistance. There is a low testosterone, there is an increase in insulin resistance, and most of the patients who are having this insulin resistance, that means the body which is secreting the insulin is not able to compensate the food we are taking, not able to break down the carbohydrates or glucose we are taking. So most of these patients will go into diabetic state for taking for long term. Anemia also is more common because testosterone is one of the most important hormone which helps in increased blood cell production. So whenever there is a low testosterone levels, there will be a decrease in a hormone called erythropoietin, which is secreted in the kidney. This erythropoietin helps. This erythropoietin helps acts on the bone marrow to increase the RBC production. So whenever there is a low testosterone, the erythropoietin will be decreased. Then obviously these patients will go into anemia. Patients who are having metastatic disease to the bone, they also have anemia because of the loss of bone marrow. Coming to gynecomastia, that is enlargement of male breast because of increased production of estrogen. This is more common in androgen deprivation therapy, low testosterone. Because of the conversion of testosterone to estradiol, estradiol is nothing but estrogen, which increases on patients who are having low testosterone. So patients can present with enlargement of the breast. Sometimes they can be having tender breast also, that is called as mastrodynia, that is tenderness in the breast. How we can avoid is some patients who are symptomatic can be given prophylactic radiation, giving radiation to the breast area so that it will reduce the pain and it will reduce the enlargement. Patients who are having significant enlargement of breast can undergo liposuction, that is removal of fat from the breast, or subcutaneous small mastectomy, removal of that fat from the underlying breast. Few patients we give tamoxifen, which is a estrogen receptor antagonist, which we commonly give during a CA breast. So that also can be used in this scenario where we can decrease the pain in the breast area. Cardiovascular effects. So patients who are taking agonist, leuprolide, can have a little bit of increased cardiovascular risk than compared to patients non-antagonist. But this is not yet proven. The risk is especially higher in patients who already have a cardiovascular disease, like patients who are having hypertension and cardiovascular disease. The risk is little higher than compared to patients not having any risk. So what causes this is when we give agonist, there will be increase in testosterone by increased FSH and LH level. This FSH can cause a plaque rupture or any cardiovascular events. So patients who are having history, we usually advise them to take antagonist. Antagonist is degarelix. So this is one study where they compared both leuprolide and degarelix, both agonist and antagonist. What they came across is there is no significant difference in patients who are not having any pre-existing disease. But there is a slightly significantly few events of death when compared to other patients who are having a already pre-existing disease. So those patients who are having cardiovascular risk factors, patients who are having impending spine fractures because of the metastasis disease, we give antagonist, that is the costly one, that is degarelix, which is a single loading dose with a monthly dose. So this is the flow chart which consists of how you can take care of the side effects, like giving calcium supplementation, vitamin D supplementation, doing DEXA scan and assess the patient for the risk of fractures, and giving denosumab or zoledronic acid for symptomatic patients. And the patients who are having sexual dysfunction, we can do intermittent androgen deprivation therapy. That means stopping the hormone injections in between and waiting for the PSA to rise. Whenever the PSA rises to some extent, we'll again start them on hormone therapy. So in between this starting of hormone therapy, there will be a period where they won't be having any hormones. So that testosterone will rise again and they'll have a normal sexual function. So I just want to highlight this thing, how we can prevent long-term ADT. See, giving ADT is of two types. Whether to give continuously, like 3 years you are taking continuously, every 3 months you are taking. The other way is giving intermittently. Patients particularly who are having metastasis, we cannot give continuous ADT for long time, up to 4 years or 5 years. It will cause more side effects than the benefit to the patient. So this is a recent thing where they're giving intermediate. Intermediate thing is they'll give the hormone therapy, they'll give the leuprolide injection. PSA will come down to 0.5 or 0.2. Then we'll stop the leuprolide injection and we'll serially follow these patients. Serially follow the patients. Monthly we'll do PSA. Once the PSA is touching 4, initial PSA can be 1, then the next month PSA can be 2, then the next month PSA can be 4. Whenever the PSA touches 4, no, then we'll restart the hormone therapy again. So in between these 3-4 months, patient need not be on continuous suppression therapy. He can regain his sexual function. He can regain the bone mineral density can be a little better. Cognitive function can be a little better. Quality of life will be comparatively a little better. So this is called as intermittent versus continuous ADT. It is proven that intermediate is having the increase the quality of life. So there is a minimal difference in the quality of life, but when compared to continuous therapy, it has a better quality of life when compared to continuous ADT. So yeah, I'll stop it here. So the main thing what you need to know is you should know the side effects because you will be experiencing the side effects. You should have a minimum knowledge on what are the therapies are available to decrease the side effects. And you should know about continuous and intermediate androgen deprivation therapy, which you can ask your physician, which you can ask us when you come to follow up, so that we can explain you in a better way that you'll be falling into that. If you're able to have a good follow-up, we can put you on intermittent ADT and we can do a monthly PSA so that you need not have the side effects in between. Thank you. So if there anything I can clarify your doubts and any questions, so please let me know. Just open the chat box. Yeah, please unmute yourself one by one. You can ask me any questions if you have any doubts. I feel this AD androgen deprivation therapy scientifically or it is very deep to understand how it acts, why we are giving to you. But I think you need to know at least the salient features, which is the basic points why we are giving, and you should be able to understand the side effects so that you can pick up early and get control over it, and we can approach so that we can prevent the
Muthukumar sir, you have unmuted. Kindly ask your doubt, sir. Doctor is here to answer.
It is very informative. Thank you very much.
Thank you. I feel privileged because I was able to I'm trying to cut down the things as basic as possible, but I don't know how we are able to understand it. So I was very.
I understand, sir. That is why I said that so much of information you have to give it in a so short time. Yeah. You have done it very nicely, Doctor.
Okay, hope you understand. Yeah, thank you. Anything, sir, anything like any silly doubts also you can ask me. I'll just try to clarify you so that it will.
If you have anything related to prostate,
yes,
also you can ask.
Yes, sir. Sivaraman, sir, you can.
Thank you, Doctor, for an excellent information. And of course, it's too much for us to consume within the short period, but we could understand a lot of things. Thank you very much for that. And Now, suppose the people who underwent this AD, we can understand what are the things and everything. For people who are not undergone and they have gone for the prostate removal or anything like that, the androgenic level will not come down.
You're saying the patients who are undergoing for radiation, or you're
No,
doing for surgery?
Those who have undergone the operation, like operation removal of partly the gland, or in my case, it was removed because it was not malignant.
Okay.
I had a problem with the urination, and that is why it was.
Yours is a simple prostatectomy.
Simple, yes.
Okay.
And the androgenic level still remains high.
Yeah. For you, we are not doing any suppression. We are just to clear the prostate to have a good urinary flow. Because it's a big gland, probably, that's why you would have undergone surgery by robotic approach, so that you get a maximum benefit in a single procedure.
So the high level of androgenic concentration in the body, does it make any difference or sense?
No. It won't be in high levels. It will be in a normal range only. Just because you have undergone a simple prostatectomy, your levels won't be higher when compared to the normal individual. It will be in the same normal range only. The problem when you give a testosterone patient, you have seen younger guys who go to gym, take steroid injections. So those patients who are taking testosterone supplementation, testosterone depot injections without proper prescription. So those patients will have a side effect. So they have a higher testosterone levels. Initially, it will be good. But what causes is the testosterone, higher levels of testosterone invariably blocks our body production of testosterone, and eventually they have low testosterone levels in coming months, and it will affect the testis will shrink in size. All this they don't understand. I'm just telling you, because you said that high levels of androgens, it won't be there in our normal individual's case, but patients who are taking without prescription of doctors that they take this testosterone doses and steroid doses, those patients will be in trouble, not us. Our levels will be normal. So patients who are on ADT, on testosterone supplementation, should have calcium medication. Should have, this is the most important point, should have daily supplementation of calcium and vitamin D supplementation. If you are not taking, please take it on a regular basis. It won't cause any renal stones. It won't cause you any trouble, but you require this dosage. Because will be going into osteoporotic stage. So to prevent it, you need to have a supplementation. And regular 1 kg dumbbell vessel, you need to do a small exercise regularly. Brisk walking for 20 minutes every day. That also will help.
How popular is this ADT in India, doctor?
All patients on cancer prostate, invariably in some point of time, I will say 50%, invariably in some point of their treatment, they will be taking the suppression therapy. Whether doing orchidectomy or hormone therapy, it depends upon the patient's individual thing, and the patients who are in a town, who are not in a village, rural area, they can't take this hormone injections. So those patients who are uneducated, low socioeconomic, they will tend to do orchidectomy better than giving injection for them. They will be losing the follow-up. When they lose follow-up, no, they can come when the disease will be in aggressive state. So those patients, I think, will be benefited with the orchidectomy. But most of the, I say 50% of the patients will be needing this suppression therapy in some point of their treatment line, whether after surgery or in some patients when the diagnosis itself will be in a metastatic state. To be in a cure, to control the disease, will be giving. In surgery, when we remove the prostate, if they're having high risk factors or nodal disease, then we'll give them right away. Patients who are undergoing radiation should always get a hormone therapy. Patients who are undergoing surgery should be plus or minus. If they don't have futures, we won't give androgen deprivation therapy. We'll just keep him on follow-up with the PSA. If the PSA is elevated only, we'll give them. Otherwise, they won't be requiring in their lifetime.
Thank you, doctor.
Okay. Thank you everyone.
Thank you, doctor. Thank you so much. Yeah, so on behalf of the IPCF support team, I'm glad to express my vote of thanks here. I thank Mr. Abhishek Kumar Jayswal for squeezing time amidst his schedule to impart knowledge on the mudras with us. And I thank Dr. Manoj for the valuable information that he shared and educated us with it. I thank Mr. Rishi, our hosting partner, who has helped us to have an undisturbed program. I thank all our staffs who have been part of this to make it happen. And above all, I'm really thankful to all the IPCF Support Group members who made themselves available to participate in this meeting, making it a really successful one. Thank you so much, all of you all. And I have one small announcement to make. We have a free ortho consultation camp on Friday, which is tomorrow. It is going to be Dr. Arun Kumar T, who is going to be the orthopedic surgeon, who will be doing this free camp from evening 4 o'clock to 7 o'clock. So here is the poster to your notice. So whoever, you can share it with your friends, and you can also make use of it. So thank you so much for making it a great success, the IPCF support meeting in the month of April. Thank you so much, all of you all. Thank you. This is Charu here on behalf of CURI. So we are closing the meeting here. Thank you all. Thank you so much.